Paying for patients' tissue, Part 2. Investigators' obligations to individuals from whom they seek tissue for research. There are three distinct obligations that an investigator who seeks access to tissue might have toward an individual whose tissues, upon removal from the body, might hold value for biomedical research. See the table. In addressing each of these obligations, it is necessary to distinguish between situations in which the tissue constitutes excess material that remains after an indicated clinical procedure and those in which obtaining the tissue imposes an incremental inconvenience, burden, or risk. Consent. Residual clinical tissues, such as those at tissues in the case of DF, are obtained as a byproduct of necessary care, involve no increased potential for harm or discomfort to the patient, and entail no extra effort or inconvenience beyond that inherent in the patient's medical treatment. Although consent is not always required for the use of residual clinical tissue, as with pre-identified tissues obtained from pathology department archives, current U.S. regulatory standards require more investigators to obtain the individual's consent whenever they prospectively intend to use residual clinical tissue for research. Of course, investigators must also obtain informed consent before undertaking additional procedures beyond necessary clinical care to procure tissues for research. Compensation for effort and burden. By definition, the use of residual clinical tissue for biomedical research imposes no additional effort, burden, or risk on the patient. As a result, no compensation for such effort is owed. By contrast, when the procurement of the tissue imposes burden over and above those required for indicated clinical care, it may be necessary to offer individuals, whether patients or healthy volunteers, compensation. Ample precedent exists for offering payment when individuals are asked to cooperate with physicians or investigators for the benefit of others. For example, in research contexts beyond that of tissue acquisition, subjects are commonly compensated for time, effort, and cooperation that participation requires. Similarly, payments are often made when renewable resources are procured from volunteers, not for their medical benefit, but solely for the benefit of others. This is reflected in markets that exist for blood and blood derivative, oocytes, sperm, and breast milk. Although many individuals do not demand payment for these tissues, as reflected by the largely volunteer supply of bank's blood, it is widely acknowledged that, as in the case of Ted Slavin, individuals may seek payment for these renewable tissues. In the light of Moore decision and other legal precedents holding that individuals do not retain property ownership over removed tissues, we suggest that a plausible rationale for justifying such payments is that they are made in exchange for the performance of a service. Go back up. Rather than the transfer of property. Rights to revenue streams. Cases such as LAX and DF pose the question of whether investigators and institutions owe individuals payments for the potential value of the tissue, and in particular whether contributors should have rights to the portion of any revenue stream that derives from their tissue. As discussed, neither legal norms nor contemporary practice treats tissues that have been separated from the body as the ongoing property of the individual, such that it would generate a revenue stream. Nevertheless, beyond legal duties, do ethics require that individuals whose tissues ultimately provide revenue for institutions and investigators be offered a share of the proceeds? Several considerations mitigate against the claim that patients such as LAX or DF should be offered financial compensation for the use of their residual clinic tissue. First, although it is true that the patients have contributed raw materials necessary for development of the cell line, it is the investigators, not the patients, whose intellectual contributions lead to the creation of value. Second, paying such individuals raises the question of fairness. Investigators may preferentially reward patients and families with whom they have become emotionally bonded, but not those who were generous, but with whom personal relationships were absent. Third, the implications of reconceptualizing tissue acquisition as an economic exchange rather than a gift relationship must be carefully considered. Payment might paradoxically have negative effect on patients' willingness to give their tissues for research. Providing upfront payments to all patients who donate tissue, independent and without prior knowledge regarding the actual financial value of the contributions, suggests that payments themselves would likely be quite modest. The enormous number of tissue samples collected, as compared with the relatively small number that acquire significant value, suggests that prior estimated value of any given tissue sample is low. Such small payments might not merely fail to incentivize patients, but might actually be scorned as an unfair or token reward. In addition, scroll back up here. Yikes. There is a risk that invoking the intrinsic motivation of money would crowd out intrinsic motivations, such as the desire to contribute altruistically to improve knowledge and treatment. Finally, and perhaps most important, few individuals will contribute tissues that generate financial blockbusters. As a result, compensating such persons in effect rewards them for winning the lottery, whereas the vast majority, despite their ex-ante identical contributions, receive nothing. If financial rewards for the development of useful cell lines should be tied to material contributions rather than to luck, then compensating patients such as LACS or DF, ostensibly in the service of justice, may lead to an outcome that is manifestly unjust. Conclusion. Although Skloot's book is moving and compelling, we use caution in using Lack's example as a model for thinking about compensating patients who provide tissue for research. Although one can point to the many injustices Lack endured as a poor woman without access to needed medical care, the use of her residual clinical tissue involving no additional risk or burden to her does not demand any form of compensation. Furthermore, compensating such patients may have unintended consequences that could work to decrease the availability of tissue for research and may, paradoxically, become a source of injustice. In the case of DF, we therefore advise the investigators not to offer his family any payments for the use of residual tissue they obtained. Thank you for listening and following along. Bye.